Hello, everyone. Thank you for joining this webinar on the basics of Factor VII deficiency. I hope everyone is staying safe and healthy during this pandemic. I'm Suchitra, Acharya at the Cohen Children's Medical Center of New York, and I would like to thank NHF for this opportunity and Chelsea and Jasmine for organizing this session. In the next 30 minutes or so, I will discuss the role of Factor VII in the clotting process, the clinical presentation of Factor VII deficiency, diagnostic testing and treatment options for an individual with Factor VII deficiency, and finally, focus a little bit on girls and women with Factor VII deficiency. These are my disclosures, none of which are relevant to the presentation today. I would like to start off with a vignette because this is like a real world case which actually demonstrates some of the bleeding symptoms that can occur in a patient with Factor VII deficiency. So we were referred the 7-year-old female after she was oozing for about 2 days after she had a tooth pulled, and the oozing would not stop despite pressure with gauze and ice. Going back into her history, the parents reported that she had a history off and on of bilateral ankle pain and swelling, for which they had seen an orthopedist who had done x-rays on her and notified them that he saw some bony changes in her right ankle. Also, her 10-year-old brother, who's an avid soccer player, reported an episode of severe joint pain and swelling while playing soccer. And he had an episode of a severe nosebleed which lasted 30 minutes, for which they had to go to the emergency room to get his nostril packed. Both parents are first cousins from Ecuador. Just keep this background in mind because eventually we will get to the diagnostic testing and how we managed this young girl. So in order to understand the role of Factor VII in the clotting process, I would like to share this visual representation of how a blood clots, which has been developed by doctors Usha Reddy and Roshni Kulkarni. Sorry, just give me a minute to pull this up. Okay, so this visual represents a blood vessel, which is a tube lined by endothelial cells that you can see here. And there are two components in the blood: cells, red cells, white cells, and platelets. And the liquid component, which we refer to as plasma, which contains clotting proteins, proteins that help in clot formation, proteins that prevent clot formation, and proteins that are involved in clot breakdown. So with any kind of injury, whether it's due to trauma or a surgical procedure, there's breach in the continuity of the vessel wall. And platelets are the first cells to go to this site of injury. And what platelets do is they bind to the lining of the vessel as they are activated. And as more and more platelets get activated, they recruit more platelets to the site. And these platelets then stick to each other in a process referred to as platelet aggregation in order to form a platelet plug. Simultaneously, when platelets are being recruited to the site to form a platelet plug, clotting proteins in the blood also become activated. So tissue injury releases tissue factor, which then activates Factor VII to form activated Factor VII. And subsequently, other components of the extrinsic pathway, the intrinsic pathway, as well as the common pathway, all group together to form a fibrin clot, and Factor XIII eventually is required for cross-linking of the fibrin network in order to form a tensile fibrin clot. This is a very important process because unless and until you form a tensile fibrin clot, you cannot begin the healing process. And soon after a tensile clot is formed, the healing begins, healing is completed, and the vessel returns to normal. And so factor VII is classified as a rare bleeding disorder because it occurs in 1.5 million individuals. And rare bleeding disorders comprise 3 to 5% of inherited bleeding disorders after von Willebrand's disease and the hemophilias. There are two reports, a report that was published by the World Federation of Hemophilia and a report by the European Network of Rare Bleeding Disorders, spearheaded by Dr. Flora Paivandi in Milan, Italy, that have reported that factor VII is the most common of the rare bleeding disorders, occurring at a prevalence of around 37%. The prevalence of rare bleeding disorders has been noted due to registries that have been established in the UK, Italy, and Iran. And as a result of these registries, we have vastly improved our knowledge of these rare bleeding disorders. In the slide, you will find a table showing you the prevalences of the hemophilias, factor VIII and factor IX deficiency, which is similar in the UK, the Italy, and Iranian registries. However, when you look at the prevalence of factor VII deficiency, you see that it is 3 to 5-fold higher in the registry reported from Iran as compared to the registries in Italy and the UK. And why is that? The reason for this is a high rate of consanguinity, which is first cousin marriages, uncle-niece marriages that are common in countries like Iran and other countries in the Middle East and Southeast Asia. And the rate of consanguinity reported is anywhere from 40 to 85%, which translates into a 3 to 7-fold higher prevalence of rare bleeding disorders in the Middle East and Southeast Asia as compared to the Western world. Factor VII deficiency is autosomal recessive in inheritance, which means that both parents have to carry the mutation in order for a child to manifest the disorder. As you can see in this pedigree, there is an affected boy, there's an affected girl, and there's a boy who's a carrier, and both parents are carriers. And therefore, in an autosomal recessive disorder, with every pregnancy, there is a 25% chance of a child being affected. The World Federation of Hemophilia reported that factor VII deficiency is equally distributed amongst males and females, males represented in red, females in blue, which is unlike the hemophilias, which are predominantly represented in males because of the X-linked recessive inheritance. Now, one of the interesting things with factor VII deficiency is that factor VII levels do not correlate with bleeding symptoms. And Dr. Paivandi's work from the European Network of Rare Bleeding Disorders reported that a little over half the patients with factor VII deficiency actually do not have any bleeding symptoms. About 17% can bleed with trauma, and 22% actually have minor bleeding symptoms such as mild spontaneous bleeds in areas such as the mouth, the nose, skin, and sometimes heavy menses in females. Only 7% of individuals with factor VII deficiency tend to have major bleeding symptoms such as bleeding into the joints and muscles, bleeding into the gastrointestinal tract, umbilical cord bleeding, and intracranial bleeding. Dr. Mariani from Italy established the STIR registry way back in 2007 and reported that bleeding into the skin and lining areas occurs in about 30% of individuals with factor VII deficiency, while other sites such as the brain, the muscle, intestines, kidneys, umbilical cord, joints tend to be less common in under 15%. So clinical symptoms predominantly involve skin and lining areas in the form of petechiae, nosebleeds, gum bleeds, heavy menses, prolonged bleeding at labor and delivery, and rarely excessive bleeding at procedures, including circumcision. The more frequent symptoms reported in severe factor VII deficiencies include intracranial bleeding, joint bleeding, soft tissue hematomas, and umbilical cord bleeding. Whenever an individual presents with severe bleeding symptoms, we do screening tests such as the complete blood count to estimate if the individual has developed any form of anemia which needs to be treated, as well as coagulation tests such as the prothrombin time, which screens for factors 2, 5, 7, and 10, and the partial thromboplastin time, which screens for factors 8, 9, 11, and 12. And so in an individual with factor VII deficiency, the prothrombin time tends to be prolonged. After noticing a prolonged prothrombin time, the next step is to actually measure individual factor levels that is screened for by the prothrombin time. And most laboratories, the factor VII level less than 70% is diagnostic of factor VII deficiency. However, patients, unless and until they have levels less than 30%, do not tend to have bleeding symptoms. So the factor VII level that we talk about is the factor VII activity assay. We also need to do a factor VII antigen, which quantitates the amount of factor VII protein that is produced. And once a diagnosis is established, it would be important also to look for genetic mutations in the factor VII gene in order to identify other individuals at risk and for future progeny. As mentioned earlier, there's a weak association between factor VII level and bleeding symptoms. And based on data, again, from the European Network of Rare Bleeding Disorders, there are individuals with levels less than 20% who may have significant bleeding symptoms, whereas there are patients with less than 1% levels who do not bleed. And therefore, the European Network recommended classifying factor VII deficiency as severe deficiency when levels are less than 10%, moderate deficiencies for levels between 10 and 20%, and mild deficiencies levels more than 20% but less than 70%. Treatment options for factor VII deficiency are very effective, and the most preferred treatment is a recombinant factor VII product, which is made in the laboratory. It's effective, but needs to be given more frequently in order to maintain factor VII levels above 20% to reduce the risk of severe bleeding. There is a small risk for inhibitor development, that is an antibody to factor VII, which occurs in about 2% of severe factor VII deficiency. And there may be a risk also of thrombosis or developing a blood clot, which is an interesting observation, which is not very well understood. If for some reason recombinant factor VIIa is not available, other options include fresh frozen plasma. The disadvantages of fresh frozen plasma is that it's not virally inactivated, and also a large volume needs to be infused because of the low concentration of factor VII in plasma. And it also carries the additional disadvantage of potential transmission of blood-borne pathogens. Prothrombin complex concentrates contain factors 2, 7, 9, and 10, and can also be used to treat a bleed or prior to a procedure in a patient with factor VII deficiency. The advantages being it is purified, as well as the volume of infusion is low. There may be a risk of thrombosis with repeated dosing in the perioperative setting. Apart from these replacement products, antifibrinolytic agents or clot strengthening agents such as aminocaproic acid and tranexamic acid also play a major role in the therapeutic armamentarium of factor VII deficiency. And the reason for this is lining areas produce an abundance of clot breakdown enzymes. And so these antifibrinolytic agents, by strengthening the clot along with replacement products, help control bleeding. Treatment strategy in an individual with factor VII deficiency can be based on age and the type of bleeding at presentation. As mentioned earlier, skin and lining areas or mucocutaneous bleeding can occur at any age and is generally mild. So most times they may not require treatment or can be used, and can be treated on demand with the use of antifibrinolytics such as aminocaproic acid and tranexamic acid with or without recombinant factor 7A. Heavy menses in teenaged and older women could be mild or severe, and prophylaxis could be used only during the menses with antifibrinolytics and recombinant 7A, or it may be used only on demand. Joint bleeds, which tend to occur in toddlers and older children, tend to be severe in somebody with severe factor 7 deficiency, and these individuals are the ones who go on prophylaxis. Intracranial bleeds and gastrointestinal bleeds, which can present in the newborn period, tend to be very severe. And in these individuals, long-term prophylaxis with recombinant factor 7A is highly recommended. So is there a role for prophylaxis in factor 7 deficiency? This is usually determined by bleeding frequency, the severity of the bleed, as well as the risk for long-term sequelae. Two types of prophylaxis can be envisioned. Primary prophylaxis is before any major bleeding occurs in order to prevent intracranial hemorrhage. And secondary prophylaxis is implemented after a bleeding event in order to prevent a life-threatening bleed or recurrent joint bleeds. However, data in factor 7 deficiency and the benefits of prophylaxis is sparse, but we know that it is feasible. Despite the short half-life of factor 7, which lasts about an hour to 3 hours, and therefore prophylaxis is usually indicated in infants with severe deficiency who may be prone to severe and frequent bleeding. It is also indicated in severe disease when a child develops an intracranial bleed or a severe gastrointestinal bleed or repeated joint bleeds, and a female with heavy menses with extremely low factor 7 levels. And prophylaxis is doable either 2 to 3 times a week or on an every other day schedule, and sometimes may be required on a daily basis with recombinant factor 7A, depending upon the response of the patient to factor 7A and the bleeding frequency and how well the bleeding is controlled with prophylaxis. The STIR registry has reported that bleeding symptoms at diagnosis actually can predict subsequent bleeding events in an individual with factor 7 deficiency. So let's say, for example, a patient is identified with low factor 7 levels because of pre-op screening and a prolonged PT is identified leading to a diagnosis of factor 7 deficiency, and this individual is completely asymptomatic, has not suffered from any bleeding events. This individual's risk for subsequent bleeding events is much lower than an individual who presented with a minor or a major bleeding event and then was diagnosed with factor 7 deficiency as a cause of that bleeding event. Girls and women with factor 7 deficiency have a lifetime risk of bleeding, especially those with severe factor 7 deficiency during menses, pregnancy, and around the time of delivery or postpartum. Heavy menstrual bleeding has been reported in about half of the girls and women with severe factor 7 deficiency. And apart from heavy menstrual bleeding, girls and women can also develop bleeding mid-cycle during ovulation and develop a condition called hemoperitoneum, which is bleeding into the lining of the abdomen. And this could be a life-threatening event and is an emergency which needs to be addressed immediately to prevent serious bleeding. Very high rates of postpartum bleeding have also been reported in women with severe factor 7 deficiency. Heavy menstrual bleeding really needs to be addressed in a teenager who presents with with the bleeding phenotype in factor VII deficiency, because this teenager can go on to develop severe iron deficiency, and iron is required for higher functions such as focus, concentration, and so her ability to do well in school is really adversely affected. Apart from that, there's limitation in daily activities with a reduced quality of life, time lost from work and school causing adverse psychosocial events, and women with heavy menstrual bleeding tend to undergo repeated hospitalizations, which can increase maternal mortality. Management of heavy menstrual bleeding depends upon whether a woman is considering pregnancy soon or not. If a woman is considering pregnancy soon, treatment options would be the use of recombinant factor VIIa during her menstrual cycle, along with tranexamic acid or aminocaproic acid clot strengthening agents. If pregnancy is not being considered soon, hormonal control in the form of a levonorgestrel, IUD, a combined oral contraceptive pill, or a progesterone-only pill are good options. If reproduction is completed, endometrial ablation and hysterectomy are other treatment options to be considered. Pregnancy in a woman with severe factor VII deficiency should really be managed at a bleeding disorder center or a hemophilia treatment center, and replacement therapy should be based on the woman's past bleeding history and sometimes may need to start as early as the first trimester. All women should be carefully monitored through a multidisciplinary team approach involving not only the obstetrician, but the hematologist, along with the anesthesiologist, primary care physician, with access to a lab 24/7 for monitoring of levels. Epidural anesthesia can be used, but make sure that levels are more than 50% at the time of catheter placement and 24 hours after removal of the catheter. The route of delivery, vaginal versus C-section, should be based on what is safe for mother and child. And postpartum hemorrhage, which can occur in women with severe factor VII deficiency, should be strongly considered and discussed with the patient, as well as the risk for late postpartum hemorrhage, which can occur up to 2 weeks after delivery, should also be addressed. All women with severe factor VII deficiency should have a CBC check before discharge and counseled about excessive bleeding and follow-ups. For the suspected newborn, vaginal delivery can be conducted in a woman with severe factor VII deficiency, but if the second stage of labor is prolonged, avoid using forceps, vacuum, or fetal scalp monitoring in order to prevent an intracranial hemorrhage. And if the second stage of labor is prolonged, go right away to a C-section without the use of these other interventions. Once the baby is born, cord blood can be sent for factor VII levels, and a screening head ultrasound should be done to rule out an intracranial bleed. The mother should be educated to report symptoms of vomiting, lethargy, and seizures, which can be presentations of delayed intracranial hemorrhage, which can occur up to 7 days after delivery. All babies need to receive vitamin K, but in general, any vaccines should be administered subcutaneously rather than intramuscular injections in order to avoid muscle bleeds. There is a risk for inhibitor development, although this risk in the newborn is not very well known, and therefore avoid elective procedures as much as possible in the newborn period. And all newborns who are diagnosed with severe factor VII deficiency should be referred to a hemophilia treatment center or a bleeding disorder center for ongoing management and comprehensive care. So going back to our patient who presented with the oozing after dental extraction and who has a history of multiple joint bleeds, along with her brother who has a history of joint bleeds and nosebleeds, We investigated this girl further and found that she had a prolonged PT, prothrombin time, at 22.5 seconds with a normal partial thromboplastin time. And her factor 7 level was 2%, the activity, and the antigen was 5%, diagnosing her with severe factor 7 deficiency. So she was treated with recombinant factor 7A for a day, along with aminocaproic acid for 7 days with prompt bleed resolution in her mouth. And subsequently, she was started on secondary prophylaxis with recombinant factor 7 every other day in order to prevent her recurrent joint bleeds. Thank you so much for your attention, and it would be very helpful if you could fill out the session evaluation in order for us to understand how to improve these sessions for the future. Thank you so much.